Welcome back to the deep dive. Imagine a condition that affects millions globally, constantly presenting complex management decisions in clinic chronic venous disease of the lower limbs. It's incredibly common, right? But with new endovenous techniques and evolving understanding, figuring out the best way forward for each patient can feel like navigating a rapidly changing landscape.
It really can. And for any specialist clinician knee-deep in managing these patients, staying on top of the absolute latest evidence and consensus is crucial. That's exactly why we're here today.
Our guide, our source material for this deep dive, is the definitive word from across the pond. The European Society for Vascular Surgery, the ESVS 2022 Clinical Practice Guidelines on the Management of Chronic Venous Disease of the Lower Limbs. This isn't a minor tweak from their 2015 version. It's a significant update incorporating years of new evidence and the collective wisdom of experts.
Our mission, specifically designed for you, the specialist clinician, is to cut through the density of this expensive document. We're not just going to list recommendations.
No, definitely not.
We're going to explore the evidence behind them, delve into the practical implications, understand the rationale for updates, and pull out the clinical pearls you can apply directly in your practice when managing chronic venous disease.
So, how are we going to tackle this comprehensive guideline? We'll start by grounding ourselves in the basics, the updated classification, and the fascinating, sometimes complex, pathophysiology.
Right. Understanding the why is key.
Then we'll dive into the diagnostic tools, particularly the indispensable role of duplex ultrasound. From there, we'll build upon the foundation of conservative management before launching into the various interventional techniques for superficial, perforating, and deep venous disease.
And we need to cover those challenging scenarios too.
Exactly. We'll dedicate time to venous leg ulcers and pelvic venous disorders causing lower limb varicosities, touch on special populations, and importantly, shine a light on the areas where the guidelines themselves admit more research is desperately needed.
And crucially, we'll be highlighting the strength of that evidence. We'll mention the class of recommendation and level of evidence using that familiar ESC grading system throughout.
Perfect. So let's start right at the beginning then. Why these guidelines now? Who are they for? And what's the foundational understanding of the disease itself?
Good place to start. The European Society for Vascular Surgery put these out in 2022, really to bring the 2015 guidelines up to date with the latest evidence.
And the focus is squarely on chronic venous disease in the lower limbs, isn't it? Covering the superficial, perforating, and deep systems.
Yes, and importantly, they also look upwards into the abdomen and pelvis when pathology there is causing trouble lower down in the legs.
But there are boundaries. They explicitly state they don't cover other venous issues unrelated to lower limb chronic venous disease, or things like venous malformations or arteriovenous malformations.
Right, that's a whole different clinical area.
And the target audience, it's broad, reflecting how many different specialists deal with these patients.
It really is. Vascular surgeons, of course, but also general surgeons, vascular physicians, interventional radiologists, phlebologists, dermatologists, even emergency medicine physicians are included. The aim is consistent, high-level, evidence-based care across the board.
The process behind creating these guidelines sounds quite rigorous.
Oh, absolutely. They assembled a multidisciplinary guideline writing committee. Experts from all those relevant fields, even including a gynecologist obstetrician for the pelvic side of things.
And everyone involved was digging into the evidence, grading it, really carefully crafting the recommendations.
Transparency was a big focus too. All conflicts of interest were declared, and crucially, there was zero industry funding for the guideline development itself. That independence is important.
So how did they actually put it together?
It was a multi-step process. They defined the scope, drafted sections based on thorough literature reviews, hammered out the wording in meetings, and then sent it out for 3 rounds of external peer review by other international experts.
That's robust, and I understand patient feedback was woven in.
Yes, and that's a really positive step. They created plain English summaries and had lay reviewers go through them.
What kind of insights came from that?
Some really practical stuff. Patients highlighted frustrations like delays getting specialist referrals and real difficulties actually putting on and wearing compression garments. They stressed the need for better donning aids.
That's something we hear all the time in clinic.
Exactly. And they found the technical descriptions of procedures, ablation and things, quite complex. This pushed the committee to simplify the language used in patient materials. It really underlines how vital shared decision-making is, discussing all the options, even if they aren't available locally.
It's a great reminder that our technical solutions have to work for the actual person experiencing the condition.
Absolutely.
Okay, before we dive deeper, let's clarify a term. Chronic venous insufficiency, or CVI. The guidelines seem quite specific about its use.
They are. They reserve CVI for the more advanced stages of chronic venous disease.
So not just any venous problem.
No. CVI specifically refers to those functional abnormalities in the venous system that lead to clinically apparent consequences, visible edema, noticeable skin changes, or active venous ulcers. Think CAP clinical classes C3 up to C6.
Got it. So CVI equals advanced disease with functional impairment, not just the presence of any chronic venous disease.
Precisely.
Okay, that distinction is helpful. Now, let's talk numbers. Just how common is chronic venous disease across its different stages? There was a big systematic review mentioned.
Yes, a huge one. Pulled data from over 300,000 adults worldwide, 32 studies. The pooled prevalence estimates really paint a picture.
What did they find?
C0S, that's symptoms without visible signs, around 9%. C1, the telangiectasias and reticular veins, a whopping 26%. C2, varicose veins, about 19%. C3, edema, 8%. C4, skin changes, 4%. C5, healed ulcers, 1%. And C6, active ulcers, thankfully lower at 0.4%.
Wow. So C1 and C2, the visible but often less severe signs, are incredibly common. But even C3 edema affects nearly 1 in 10 adults in this pooled data.
It really highlights the sheer scale of the problem. C2, varicose veins, had the highest pooled prevalence of the clinical classes.
It does. Okay, moving from how many to how does it happen? Let's unpack the pathophysiology. It differs depending on which system is involved, right?
That's right. In the superficial veins, it's often relatively straightforward, primarily valve incompetence. The valves just aren't closing properly, leading to reflux, that backward flow of blood.
But the deep system is often more complex.
Yes, definitely. In the deep veins, the core issue is usually impaired venous emptying. This can be due to obstruction, reflux, or very often a combination of both.
And this is frequently linked to a past deep vein thrombosis.
Exactly. That's labeled AC in the updated CAP classification secondary cause, intravenous origin. After a deep vein thrombosis, even if the body breaks down the clot, lysis, or blood finds a way around it, recanalization, the delicate valves within that vein segment can be damaged or completely destroyed. This leads to deep venous reflux.
And if the clot doesn't clear properly...
Then you get residual narrowing, stenosis, or even complete blockage, chronic obstruction. So you can have reflux, obstruction, or both messing up deep vein function.
What about the perforating veins, the ones connecting deep and superficial?
They can become incompetent too. Their valves fail, the veins remodel and enlarge, and they allow blood to flow outwards from the high-pressure deep system into the superficial system, adding to the burden there.
And the ultimate consequence of all this deep system dysfunction, whether it's reflux or obstruction?
It's increased venous pressure, venous hypertension. This back pressure particularly affects the superficial veins and the skin. And this whole cascade, especially following a deep vein thrombosis, is the underlying mechanism for post-thrombotic syndrome, or PTS.
And if a patient has both obstruction and reflux in the deep system?
The clinical picture tends to be more severe. The venous hypertension is often worse.
Beyond deep vein thrombosis, the guidelines mention other causes of impaired emptying, the ESE category in CAA, secondary extravenous causes.
Right. This covers things pressing on the veins from the outside extrinsic compression. Think of intra-abdominal masses, or the classic scenario of the left common iliac vein being compressed by the right common iliac artery in May-Thurner syndrome.
What else falls into this ESE category?
Conditions that raise overall venous pressure. Things like right heart failure, which causes systemic venous congestion. Also, an impaired calf muscle pump if the muscles aren't effectively squeezing blood upwards. And significantly, obesity, which increases intra-abdominal pressure and impairs venous return.
So these external factors can mimic the effects of problems within the veins themselves.
Precisely. They all contribute to venous hypertension and can lead to the same kinds of symptoms and signs.
Okay, now let's focus down on the skin and subcutaneous tissue. This is where venous hypertension really leaves its mark, isn't it?
Absolutely. The microcirculation in the lower leg skin bears the brunt of chronic venous hypertension.
What actually happens to those tiny vessels?
Well, the small veins and venules in the skin, which also have valves, become incompetent under the sustained high pressure. These vessels, along with the capillaries, start to elongate, dilate, and become visibly tortuous.
And is there a correlation with what we see clinically?
Yes, a direct one. The severity of these changes in the microvasculature, which you can sometimes visualize with techniques like capillaroscopy, mirrors the severity of the visible skin. Changes the pigmentation, the eczema, the lipodermatosclerosis, the induration.
So it's not just a plumbing issue of back pressure, it's actually changing the biology down there.
Exactly. The endothelium, the lining of these small vessels, becomes dysfunctional. It starts to leak fluid, proteins, and inflammatory mediators out into the surrounding tissue.
And that triggers inflammation.
It does. You get this inflammatory cascade kicking off. This leads to edema, the deposition of fibrinogen, which polymerizes into fibrin around the capillaries, forming the so-called fibrin cuff. There's persistent inflammation involving white blood cells migrating into the tissue.
And over time, this leads to more permanent changes.
Yes, it becomes a chronic process. You see fibrosis, scarring, hemosiderin deposition, causing that typical brown pigmentation, and even calcification within the dermis. The guidelines describe this endpoint as a state of paradoxical hyperemic hypoxia, meaning there might be blood flow, but the tissue isn't getting the oxygen it needs effectively.
Ultimately leading to skin breakdown.
Ultimately, yes. The skin loses its integrity, and you get the formation of a venous leg ulcer. It's a direct pathway from the initial valve failure or obstruction through venous hypertension, microcirculatory damage, inflammation, and finally, tissue destruction.
Okay, let's quickly recap that pathophysiology foundation. Chronic venous disease is a spectrum. CVI means advanced disease, C3, C6, with functional issues like edema, skin changes, ulcers.
Right. The underlying cause can be superficial reflux, deep obstruction, often post-deep vein thrombosis, perforator incompetence, or extrinsic factors impairing outflow.
But all these paths tend to converge on venous hypertension.
Exactly. And it's that sustained venous hypertension that uniquely damages the microcirculation in the lower leg skin, driving the inflammation, fibrosis, pigmentation, and eventual ulceration you see clinically.
So for you seeing patients, understanding this pathway helps connect the dots between the underlying venous problem and the clinical signs you're assessing.
It's the essential foundation. Now let's move on to how patients actually present and the tools we use to assess the severity.
Symptoms are often the first thing patients complain about, right? The guidelines emphasize just how variable these can be and the real impact they have on quality of life. They also note symptoms tend to increase with age and are more common in women.
Absolutely. Patients might describe a whole range of things: heaviness, tired legs, a feeling of swelling even if it's not obvious, itching, cramps, especially at night, a throbbing sensation, burning pain, or just a dull ache.
And these are typically worse after being upright for a while.
Yes, characteristically aggravated by prolonged standing or sitting, and often relieved by leg elevation or walking. Although in some cases with significant outflow obstruction, walking itself can cause pain that's venous claudication.
Which we'll come back to. But here's a key challenge the guidelines highlight: attributing symptoms solely to venous disease.
It's really tricky. Patients across the entire CEP spectrum, from C0S, symptoms but no visible signs or edema, right through to C6, active ulcer, can report very similar symptoms.
So you can't just look at the leg and guess the symptom severity.
Definitely not. There's no strict correlation. Someone with minimal visible signs might have debilitating symptoms, while another person with massive varicose veins or significant skin changes might be relatively untroubled symptomatically. Plus, many of these symptoms, aching, heaviness, cramps, overlap significantly with non-venous conditions like musculoskeletal issues or neuropathy.
So are any symptoms considered more specific for chronic venous disease?
The guidelines suggest that heaviness, that sensation of swelling, burning, itching, and general pain or aching, tend to be more strongly associated with the higher CEAP classes, C3 to C6.
And what about things like fatigue, cramps, or restless legs?
Those are considered less specific. They can occur in chronic venous disease, but they're also very common in the general population or other conditions.
Okay, let's circle back to venous claudication. That sounds more distinct.
It is. It's specifically pain that comes on with exercise, usually in the calf or thigh, due to inadequate venous outflow. This happens when there's significant obstruction higher up, typically in the iliofemoral veins, the vena cava, or sometimes due to popliteal vein entrapment.
So the increased blood flow demand during exercise overwhelms the obstructed outflow pathway?
Exactly. The pressure builds up, causing pain that limits walking capacity. The guidelines mention a small study where 15% of patients after an iliofemoral deep vein thrombosis experienced this type of exercise-limiting pain during treadmill testing. It's an important symptom to ask about.
While chronic venous disease is, well, chronic, can patients experience acute complications?
They can, although acute events are generally uncommon compared to the chronic symptoms.
Hmm.
The most frequent acute complication is superficial vein thrombosis, often called SVT.
Where does that typically occur?
Usually in a varicose tributary vein or sometimes in the main saphenous trunk itself,
And why is SVT significant?
because it's not always just a local issue. The thrombus can potentially extend into the deep venous system, causing a deep vein thrombosis. And although rare, it can even lead to a pulmonary embolism.
Do varicose veins themselves increase deep vein thrombosis risk?
The guidelines state varicose veins are considered a minor risk factor for deep vein thrombosis. However, it's a bit unclear whether it's a direct causal link or if they just share common underlying risk factors.
Any other acute complications to be aware of?
Acute bleeding from a superficial varicose vein, especially if it's thin-walled and close to the skin, can occur. It can sometimes be quite dramatic and needs urgent assessment and management, usually simple pressure and elevation initially.
Okay. To help track the disease and assess treatment effects, clinical scoring systems are important tools.
Yes, they provide a more objective measure. The most widely used one for tracking changes over time, especially after intervention, is the Revised Venous Clinical Severity Score, or RVCSS.
How does that work?
It's designed for dynamic assessment by the clinician. It scores 11 different clinical variables: pain, cramping, heaviness, pruritus, itching, paresthesia, pins and needles, edema, skin induration, hyperpigmentation, venous ectasia, visible veins, redness, and calf tenderness during compression.
And each gets a score.
Each is scored from 0 absent to 3 severe, giving a total maximum score of 33. It allows you to quantify the severity of signs and symptoms at a point in time and crucially track how they change with treatment or disease progression.
What about the Villalta scale? That's often mentioned for post-thrombotic syndrome.
Right, the Villalta scale is specifically designed and validated for diagnosing and evaluating the severity of post-thrombotic syndrome. It includes both patient-reported symptoms and physician-assessed signs.
But the guidelines raise a point about its specificity.
They do. While validated for PTS, they question its specificity because many of the features it scores, pain, edema, skin changes, are also very common in chronic venous disease without a history of deep vein thrombosis. So there's overlap.
How is it scored?
Similar principle. Variable scored 0-3, maximum score 33. The total score then defines severity categories. Less than 5 is no PTS, 5-9 mild, 10-14 moderate, and greater than 14, or the presence of an active ulcer indicates severe PTS.
Beyond clinician scores, what about the patient's perspective?
Patient-reported outcome measures, or PROMs, are increasingly recognized as the gold standard for evaluating how successful an intervention is from the patient's point of view.
Which tools are commonly used?
Disease-specific ones like the Aberdeen Varicose Vein Questionnaire, AVVQ, the Chronic Venous Insufficiency Quality of Life Questionnaire, CIVQ, and the Venous Insufficiency Epidemiological and Economic Study Quality of Life Symptoms Score, VEINS-QoL-SYM, are frequently mentioned.
Are they used routinely?
The guidelines acknowledge they can be complex and time-consuming for routine clinical practice. However, their importance is growing, and they're often mandated in clinical trials and registries. They really capture the impact on the patient's life.
Okay, let's summarize this section on clinical presentation and assessment. Symptoms are highly variable, often nonspecific, though some, heaviness, swelling sensation, etc., correlate better with advanced disease.
Right. Venous claudication is a key symptom suggesting outflow obstruction. SVT is the most common acute event, with potential for extension.
Use tools like the RVCSS to objectively track clinical changes over time. The Villalta scale is for diagnosing and grading PTS, but remember its specificity limitations.
And don't forget the importance of PROMs for capturing the patient's experience and the true success of any intervention.
So for you in clinic, be thorough in symptom assessment, quantify with scores like RVCSS, specifically ask about venous claudication if exercise limitation is reported, be alert for SVT or bleeding, and consider using PROMs where feasible to understand the patient's perspective.
Absolutely. Accurate assessment sets the stage for everything else.
Now let's move into diagnosis, specifically the role of imaging. This is where we confirm the underlying problem.
And there's one tool that stands head and shoulders above the rest as the starting point. Duplex Ultrasound, DUS. It's absolutely the cornerstone for assessing lower limb chronic venous disease.
What makes it so essential?
It gives you so much information non-invasively. You can directly visualize the venous anatomy, superficial, deep, perforating veins. You can assess blood flow direction using Doppler to identify reflux, and you can assess compressibility and flow patterns to look for obstruction.
Are there specific parameters used to define incompetence on DUS?
Yes. For reflex and superficial and deep veins, a duration of backward flow exceeding 0.5 seconds during provocative maneuvers, like calf squeeze or Valsalva, is the standard criterion. Some use 0.35 seconds. For perforating veins, reflux duration is one factor, but diameter is also important, especially in areas with skin changes, C4, C6. A diameter greater than 3.5 millimeters is often considered incompetent in that context.
Duplex ultrasound seems particularly crucial when dealing with recurrent varicose veins after prior treatment.
Indispensable. You absolutely need DWES to figure out why the veins have come back. Is it recanalization? The previously treated saphenous trunk has reopened and is refluxing again? This is more common after endovenous ablation.
Or could it be neovascularization?
Exactly. The growth of new tortuous veins, often connecting back to the deep system near the site of previous high ligation, like the saphenofemoral junction. This is more characteristic after surgical stripping.
Or maybe it's just disease progression.
That's the third possibility. The original treatment might have been successful, but now there's new reflux developing in a previously healthy vein segment. Maybe the anterior accessory saphenous vein, the small saphenous vein, or new incompetent perforating veins. DUS is essential to pinpoint the exact source or sources of the recurrent reflux.
What about looking higher up in the abdomen and pelvis? When does DUS play a role there?
Abdominal and pelvic DUS is indicated when you suspect the problem originates above the groin. Clinically, this might be triggered by extensive unilateral leg edema, a venous ulcer that's difficult to heal, or visible collateral veins on the abdominal wall.
Or perhaps findings on the lower limb DUS itself.
Yes, things like finding absent or continuous non-phasic flow in the common femoral vein, or seeing extensive post-thrombotic changes should prompt you to look upstream for potential iliac vein obstruction.
Is this standard DUS?
No, it requires specific expertise. Abdominal and pelvic venous DUS is technically demanding. Factors like patient obesity or overlying bowel gas can make visualization difficult. The guidelines acknowledge this and suggest that if expertise isn't available, cross-sectional imaging like CT or MinR venography might be a better choice.
What are you looking for specifically with abdominal DUS?
If you're suspecting obstruction, you're examining the inferior vena cava and iliac veins for signs of compression or thrombosis. Findings like visible collaterals bypassing the obstruction, lack of normal respiratory variation, physicity in flow signals, or significant changes in flow velocity across a narrowed segment all point towards obstruction.
Is there a specific velocity criterion?
The guidelines mention that compared to intravascular ultrasound, IVUS, a peak velocity ratio greater than 2.5 across an iliac vein stenosis on DUS corresponds well with a significant obstruction.
And if you're thinking about pelvic venous disorders as the cause?
The abdominal DUS exam specifically interrogates the renal veins, gonadal, ovarian, or testicular veins, periuterine and perivaginal venous plexuses, and the tributaries of the internal iliac veins.
What are the key signs suggesting a pelvic source?
Finding a dilated ovarian vein, typically greater than 5 millimeters in diameter, combined with evidence of reversed flow, reflux, is highly suggestive.
Can the flow pattern help differentiate causes?
Yes. If you see spontaneous, continuous reversed flow, for example in the left gonadal vein or left internal iliac vein, it might suggest a secondary cause like upstream compression, nutcracker, or May-Thurner, or post-thrombotic changes driving that constant reflux.
Versus intermittent flow.
Right. If reflux is only seen intermittently, perhaps provoked by distal compression or Valsalva maneuver, it's more suggestive of primary isolated gonadal vein incompetence without significant upstream obstruction.
While DUS is the workhorse, when do other imaging modalities like venography or CT/MR come in?
They become essential, particularly for suspected pelvic venous incompetence, especially if you're considering intervention like embolization. Selective venography is still considered the gold standard diagnostic test in this context.
Why venography?
Because it directly visualizes the pattern and extent of retrograde flow into the pelvic veins and plexuses, shows the connections to any vulvar or lower limb varicosities, and crucially, it provides immediate access for treatment during the same procedure if needed.
What about CT or MinR venography?
They are excellent for evaluating the detailed anatomy of the abdominal and pelvic veins, looking for compression points or chronic thrombotic changes. Functional MR techniques can also provide information on flow direction and magnitude.
And intravascular ultrasound, IVUS.
IVUS is mentioned as a valuable tool, particularly for confirming and guiding the treatment of large vein obstruction, especially in the iliac segments during stenting procedures.
Okay, let's summarize the diagnostic imaging approach. DUS is the absolute primary tool for lower limb superficial deep and perforating veins. It's essential for initial assessment and for mapping the source of recurrent varicose veins.
Right. Abdominal DUS is indicated for suspected suprainguinal pathology, but requires specific expertise. Cross-sectional imaging is an alternative if needed.
For complex pelvic venous disorders, especially before intervention, selective venography remains the gold standard for confirming incompetence and planning treatment, often complemented by CT or MEMR venography for anatomical detail. IVUS aids in diagnosing and treating large vein obstruction.
Exactly. For you, in practice, DUS proficiency is non-negotiable. Know its strengths and limitations. Recognize the clinical triggers that should make you think about investigating higher up in the abdomen or pelvis, and know when to utilize venography, CT, MR, or IVUS, often in consultation with interventional colleagues. Accurate imaging diagnosis is the bedrock for choosing the right management path.
Perfect. With diagnosis covered, let's move on to management, starting with the foundational non-interventional strategies, conservative management.
These approaches are the mainstay for many patients, particularly those in the earlier CET stages, from C0S up to C5. Management of active ulcers, C6, has its own specific considerations we'll discuss later, but conservative measures are vital there too.
And these aren't just for mild disease.
No, the guidelines increasingly emphasize their role as important adjuncts or sometimes even alternatives to intervention across the board.
What falls under physical methods?
Exercise is a big one. Activities that strengthen the lower limb muscles, particularly the calf, and improve ankle joint mobility are encouraged. This enhances the calf muscle pump mechanism, which is crucial for propelling venous blood back towards the heart.
Does exercise directly help with symptoms or outcomes?
While large-scale randomized controlled trials specifically demonstrating that exercise heals ulcers or prevents recurrence are scarce, there's considerable indirect evidence supporting its benefit for improving overall venous hemodynamics and function. The guidelines clearly state it should be promoted.
What about simpler measures?
Things like regular leg elevation when resting, and potentially the use of insoles designed to enhance the foot pump mechanism during walking are also mentioned as potentially beneficial, based on smaller studies.
The guidelines also mention things like massage or balneotherapy, spa therapy.
They do, but they note there's less direct evidence supporting these specifically for improving chronic venous disease symptoms or quality of life, although they might offer general well-being benefits.
A really important point raised is the need for a holistic approach, especially for patients with more advanced disease, chronic venous insufficiency.
Absolutely crucial. There's evidence linking social and psychological factors like depression or lower socioeconomic status to poorer outcomes, particularly delayed healing of venous leg ulcers. Addressing the whole person is key.
So this involves more than just treating the veins.
Definitely. It includes counseling, providing support, and emphasizing lifestyle modifications. Simple advice like taking frequent short walks, using insoles if helpful, avoiding prolonged periods of standing still or exposure to excessive heat, and elevating the legs when seated or lying down.
And weight management is highlighted again here.
Yes, obesity is recognized as a major contributor to the development and severity of chronic venous disease. Weight loss for overweight or obese patients is a vital component of this holistic conservative strategy.
Reflecting the growing evidence for exercise, there's a specific new recommendation.
Yes, Recommendation 8 is new. For patients with symptomatic chronic venous disease, exercise should be considered to reduce venous symptoms. This is graded as Class A, Level B. It signifies that the weight of evidence favors its usefulness.
Okay, now let's talk about perhaps the most widely used conservative treatment, compression therapy.
It's a cornerstone, for sure. The guidelines categorize 4 main types: elastic compression stockings, ECS, elastic or inelastic bandages, adjustable compression garments, often Velcro-based, ACG, and intermittent pneumatic compression IPC devices.
For patients without active ulcers, C0S, C5, what's typically used?
Mostly elastic compression stockings or adjustable compression garments. Compression bandages are used more for acute edema reduction or ulcer treatment.
Is there good evidence for compression in these non-ulcer stages?
Yes, the evidence is quite solid. For relieving symptoms like pain, heaviness, cramps, and reducing subjective swelling in patients from C1S up to C3, graduated elastic compression stockings providing at least 15-20 milliliters of pressure at the ankle are effective.
And that's reflected in the recommendations.
Yes, Recommendation 9 is unchanged from 2015 and strong. For patients with symptomatic chronic venous disease, elastic compression stockings, exerting a pressure of at least 15 millimilli Hg at the ankle, are recommended to reduce venous symptoms. That's class I, level B.
What about for objective edema, C3 disease?
Compression is definitely effective here too. Recommendation 10, also unchanged, states, for patients with chronic venous disease presenting with edema, C3, compression therapy, below-knee elastic compression stockings, inelastic bandages, or adjustable compression garments providing 20-40 mmHg pressure at the ankle is recommended to reduce edema, also class I, level B.
Do different types of compression work better for edema?
The guidelines discuss comparisons. For instance, inelastic bandages might achieve a very high initial pressure, around 60 mmHg, but this pressure tends to drop off relatively quickly as edema reduces.
Compared to stockings?
Compared to standard elastic compression stockings, maybe 23-32 mmHg. Interestingly, some studies looked at using superimposed elastic compression stockings, layering them to get 40 mmHg, or adjustable compression garments set to around 40 mmHg. These were found to be as effective or even more effective for reducing pitting edema compared to high-pressure inelastic bandages, likely because they maintain a more consistent pressure over time.
What about compression for preventing or treating post-thrombotic syndrome symptoms?
This is an area where the guidelines are quite candid about the limitations of the evidence. Despite elastic compression stockings being commonly used for PTS, the evidence supporting their effectiveness for symptom relief is actually quite limited.
Really? How limited?
They mention only 3 small studies with short follow-up. 2 of these found no clinical benefit compared to no compression, and the third showed only a hemodynamic benefit, not a clinical one. So there's a definite gap between widespread clinical practice and strong supporting evidence here.
That's important to know. A crucial aspect of compression is knowing when not to use it. What are the contraindications?
This is absolutely critical for patient safety. The main contraindication is severe peripheral arterial disease. High compression should not be applied if the ankle brachial index, ABI, is less than 0.6.
What about moderate arterial disease?
Caution is advised for ABI between 0.6 and 0.9. Reduced levels of compression might be used, but only under close supervision. And importantly, you need to remember that severe arterial calcification, common in diabetes or renal failure, can falsely elevate the ABI reading, potentially masking underlying severe arterial disease.
So clinical judgment is still needed even with an ABI reading.
Always. Other contraindications listed include decompensated heart failure, specifically NYHA class I, severe peripheral neuropathy, where the patient might not feel pain from excessive pressure, certain skin conditions like active local infection or severe contact dermatitis, significant limb deformity making proper application impossible, and severe arthritis limiting ankle movement needed for some applications.
Okay. What about the other types of compression mentioned, like intermittent pneumatic compression?
IPC has a more limited role in the C0-C4 stages. It might be used as an adjunct therapy, particularly for resistant edema, or as an alternative if a patient absolutely cannot tolerate sustained compression from stockings or garments. Again, the evidence for its use specifically in PTS is considered low.
And tension-free compression.
These are more experimental methods, like water immersion therapy or fluid-based wraps. They show promise in improving hemodynamics and reducing edema potentially without the high skin pressures of traditional methods, but they're not standard practice yet.
So to recap compression for C0 C5, elastic compression stockings, 15 plus mmHg, are recommended for symptoms, class IB. Compression, 20-40 mmHg via ECS, IB, or ACG, is recommended for edema, class IB. Always check ABI and be aware of contraindications. Evidence for PTS symptom relief is surprisingly limited.
That's a good summary. For you in practice, compression remains a fundamental tool for symptoms and edema management in chronic venous disease. That ABI check is non-negotiable. And remember the patient feedback council on donning techniques and aids, as adherence is key.
Let's move on to the role of venoactive drugs, or VDs. What did the guidelines find here?
They reviewed the evidence, including Cochrane reviews and meta-analyses. The overall picture is somewhat mixed, but suggests potential benefits.
In what way?
A 2020 Cochrane review update suggested that, compared to placebo, VADs as a class may have beneficial effects on objective edema and some subjective symptoms like pain, cramps, restless legs, swelling sensation, paresthesia, and even trophic disorders.
But with caveats.
Yes. They noted VADs can have more adverse effects than placebo, and a pooled analysis didn't clearly show an overall benefit on quality of life. However, another separate meta-analysis specifically focusing on objective edema did find that 4 different VADs significantly reduced it.
Did the guidelines mention specific agents?
They do. They highlight meta-analyses for specific drugs. For example, micronized purified flavonoid fraction, MPFF, was shown in its meta-analysis to improve several leg symptoms, functional discomfort, quality of life, and reduce ankle circumference.
What about others?
Calcium dobisalate also had meta-analyses showing significant reduction in leg symptoms and discomfort and improvement in edema, with potentially greater effects in more severe cases. Other agents like horse chestnut seed extract, hydroxyethyl rudosides, HR, and red vine leaf extract also have evidence supporting their use for symptom and/or edema relief, as summarized in a table within the guidelines.
So how does the guideline committee translate this somewhat heterogeneous evidence into a clinical recommendation?
They acknowledge the differences between methodologies like Cochrane polling versus individual drug meta-analyses, but take a pragmatic approach. Given the evidence suggesting benefit for symptoms and edema for several agents, combined with their generally low cost and rare non-severe side effect profile, they conclude that VADs should at least be considered.
So not a strong must use, but a consider using.
Exactly. They retained a single generic recommendation covering VADs as a class, similar to the 2015 guidelines, but updated the supporting evidence. The recommendation is, venoactive drugs should be considered for the relief of symptoms and edema in patients with chronic venous disease. This is a Class 2 AREA recommendation. Level of evidence varies depending on the specific drug and outcome, but generally supported by Level A or B evidence for key agents like MPFF and Ruscus extract based on recent meta-analyses.
Okay. So VADs are a reasonable adjunctive option to consider alongside compression and lifestyle measures for symptoms and edema.
That's the bottom line.
Let's wrap up conservative management then. Exercise should be considered for symptoms, Class 2 array. Compression is fundamental for symptoms, 15 plus milligram Hg, Class 1B, and edema, 20 with 40 milligram Hg, Class I, always checking ABI and contraindications first. VADs should be considered as an adjunct for symptoms so edema, Class 2 array. And underpinning all of this is that crucial holistic approach, including lifestyle changes and weight management for obesity.
That covers the foundation as well.
Great. Now, let's shift gears and talk about interventional treatment, starting with the most common target. Superficial venous incompetence, essentially, treating varicose veins.
This is an area that has seen a massive transformation over the last couple of decades. Open surgical high ligation and stripping used to be the absolute standard.
But not anymore.
Not really. Now, endovenous intervention, using techniques performed from inside the vein, usually combined with removal of bulging tributaries, phyllectomies, is the widely accepted standard of care for incompetent saphenous trunks.
What about cost effectiveness? Treating veins can seem expensive up front.
Studies have looked at this. Compared to just using compression stockings for uncomplicated varicose veins, surgery was shown to be cost-effective. More recently, analyses, particularly from the UK's National Health Service, suggest that endovenous thermal ablation, EVTA, is generally the most cost-effective approach for patients suitable for those techniques.
Okay, so who are the right patients for intervention?
Patient selection is key. The strongest recommendation is for patients with symptomatic varicose veins. That's CEAP Class C2. The guidelines state, interventional treatment is recommended for patients with chronic venous disease presenting with symptomatic varicose veins, C2. This is a very strong Class 1 Level A recommendation, backed by multiple high-quality trials showing clear improvements in symptoms, quality of life, and clinical severity scores after intervention.
What about patients with edema, C3, but without prominent varicose veins?
Here, the guidelines urge caution. Edema, especially if it's bilateral, can have many causes unrelated to superficial venous reflux, like heart failure, kidney problems, lymphatic issues, medications. Jumping straight to superficial vein ablation might not fix the edema if it's not primarily venous in origin.
So what's the recommendation?
Considering other causes of edema is recommended in patients presenting with chronic venous disease and edema C3 before planning venous treatment. This is a Class I Level C recommendation based on expert consensus, basically. Do your diagnostic homework before intervening just for edema.
But what if they have both symptomatic varicose veins and edema, Class C2-3S?
That's different. In those patients, intervention targeting the incompetent superficial veins is much more likely to improve not just the varicose vein symptoms, but also the edema component, especially that the swelling is predominantly unilateral. Unilateral edema is a better predictor of response to superficial vein treatment than bilateral edema.
Where should these interventions ideally be performed? In the hospital operating theater?
Not necessarily, and often preferably not. The guidelines strongly advocate for performing endovenous techniques, along with any associated phlebectomies, in an ambulatory or outpatient setting whenever possible, provided the facility is properly equipped.
Why the move away from the main operating theater?
Several reasons. Observational data strongly supports the safety and effectiveness of outpatient procedures. It's generally more cost-effective. It allows for comprehensive treatment, treating the main trunk and the tributaries often in a single session. And importantly, using local tumescent anesthesia allows for immediate or very early ambulation, which significantly reduces the risk of venous thromboembolism compared to procedures needing general anesthesia and prolonged recovery.
So for straightforward cases identified on duplex ultrasound,
The advocated approach is initial treatment with ambulatory endovenous ablation combined with adjunctive phlebectomies if needed.
this preference for the outpatient setting is now a formal recommendation.
Yes, recommendation 18 is new. For patients with superficial venous incompetence treated by endovenous techniques plus phlebectomies, procedures should be performed in the outpatient setting where possible. This is graded Class I, Level C, reflecting strong expert consensus supporting this efficient and safe model of care.
Anesthesia is obviously critical for patient comfort and procedural success with endovenous techniques. What's the preferred method?
Ultrasound-guided tumescent anesthesia is firmly established as the preferred method for endovenous thermal ablation, EVTA, like laser or radiofrequency ablation.
What exactly is tumescent anesthesia and why is it preferred?
It involves injecting a large volume of dilute local anesthetic solution, typically lidocaine with adrenaline mixed with saline or another crystalloid, directly into the tissue surrounding the vein being treated, guided by ultrasound.
So it numbs the area.
Yes, it provides excellent local anesthesia. But it does more than that. The volume of fluid physically compresses the vein, squeezing out blood and ensuring better contact between the ablation device, laser fiber or radiofrequency catheter, and the vein wall. It also induces some vein spasm.
Any other benefits?
Crucially, it acts as a heat sink. The fluid absorbs the thermal energy generated by laser or radiofrequency, protecting surrounding structures like nerves and skin from heat damage. And because it's local anesthesia, patients can walk immediately afterwards, improving their recovery and quality of life compared to general or regional anesthesia.
Is there anything to optimize the tumescent solution itself?
Yes. Standard lidocaine solutions are acidic and can cause a burning sensation on injection. Adding sodium bicarbonate to buffer the solution makes it less acidic and significantly reduces that peri-procedural pain. This benefit has been shown in randomized controlled trials.
And that's led to another new recommendation.
Correct? Recommendation 20 is new. For patients with superficial venous incompetence treated under tumescent anesthesia, buffered solutions should be considered to reduce peri-procedural pain. That's a Class IDA, Level B recommendation, supported by good trial evidence.
What about the safety of the lidocaine dose? You're injecting large volumes.
The guidelines mention that doses up to 15 millikilograms of lidocaine used in standard tumescent formulas have minimal side effects, well below the levels where systemic toxicity becomes a concern, around 35 millikilograms. The adrenaline added helps prolong the anesthetic effect and provides vasoconstriction, reducing bleeding. They do caution practitioners to be aware of local regulations regarding drug formulations and to keep any additives relevant and necessary.
When might general or regional anesthesia still be used for superficial veins?
They're now largely reserved for traditional open surgery, high ligation and stripping, or perhaps for very extensive tributary disease requiring numerous phlebectomies, or if a patient is undergoing concomitant deep venous intervention at the same time. Interestingly, tumescence is sometimes being used even with modern open surgery now.
How does this changing role reflect in the recommendations?
Recommendation 21 has been changed. It now states, for patients with superficial venous incompetence undergoing high ligation stripping, ultrasound-guided tumescent anesthesia may be considered as an alternative to general regional anesthesia. This is a Class I Level C recommendation. It acknowledges tumescence is an option even for stripping, but the evidence base is less strong than for its use with EVTA, hence the weaker may be considered.
Okay, let's talk about what happens after the procedure, post-procedural care, particularly compression. What's the rationale?
The thinking behind post-procedural compression is multifaceted. It aims to keep the walls of the treated vein coapted, pressed together, to encourage sealing and fibrosis. It's also intended to prevent or minimize inflammation, reduce pain, bruising, bleeding, and hematoma formation, and potentially to reduce the risk of superficial vein thrombosis or deep vein thrombosis.
Is standard compression sufficient?
The guidelines mention an interesting point. Achieving truly effective compression of the great saphenous vein in the thigh while the patient is standing requires pressures exceeding 40 millimilli Hg. This is difficult to achieve consistently with just a standard compression stocking alone.
So how can higher pressure be achieved?
One method suggested is using an eccentric pad placed directly over the treated vein tract underneath the compression stocking. A small randomized controlled trial found that thigh-level elastic compression stockings combined with such pads were more effective in reducing side effects compared to just using standard 23 mmHg stockings.
But is the benefit of post-procedural compression universally accepted?
This is where it gets a bit nuanced. Several randomized controlled trials have compared using compression versus no compression after endovenous thermal ablation or ultrasound-guided foam sclerotherapy. The results have been somewhat conflicting and difficult to compare directly due to variations in the type of compression used, the pressure applied, the duration it was worn, and how well patient compliance was reported.
What did the largest trial show?
The largest one mentioned involved 400 patients after endovenous laser ablation, EVLA. It compared standard 23-32 mmHg elastic compression stockings versus no compression. The group wearing stockings reported less pain and edema, but only during the first week after the procedure. By the second week, the outcomes were similar between the groups.
So the optimal duration is also unclear.
Very unclear. Practice varies widely, from just a few hours to several weeks. There's no real consensus based on strong evidence. The guidelines suggest duration should probably be decided on an individual basis.
Given this conflicting evidence, what's the final recommendation on post-procedural compression?
Despite the heterogeneity, the committee leaned towards recommending it, albeit with a should-be-considered strength. Recommendation 22 has been changed and states, for patients with superficial venous incompetence undergoing ultrasound-guided foam sclerotherapy or endovenous thermal ablation of a saphenous trunk, post-procedural compression treatment should be considered. This is graded class TI, level A, reflecting that while individual studies conflict, the overall body of level A evidence, from multiple RCTs, suggests a potential benefit, making it reasonable to consider.
The guidelines also flag the importance of venous thromboembolism risk after these procedures.
Yes, they include new recommendations, 25 and 26, both Class I C consensus, emphasizing the need for formal venous thromboembolism risk assessment for every patient undergoing superficial venous intervention, and for implementing individualized thromboprophylaxis strategies based on that risk assessment.
And follow-up imaging.
Another new recommendation, 27, Class I C consensus, suggests that duplex ultrasound surveillance between 1 and 4 weeks after superficial venous interventions is recommended to check for complications like endovenous heat-induced thrombosis, EIND, or deep vein thrombosis.
Okay, let's dive into the specific techniques used to treat the main saphenous trunks. The big historical comparison is endovenous thermal ablation, EVTA, versus traditional high ligation and stripping, HLS.
Right. EVTA encompasses techniques like endovenous laser ablation, EVLA, and radiofrequency ablation, RFA. Numerous systematic reviews and trials have compared these head-to-head with HLS.
What's the verdict?
In the short term, typically looking at outcomes within the first 1 to 3 years, EVTA comes out clearly superior. Patients report better outcomes, have better clinical severity scores like RVCSS, better quality of life, and fewer complications, less postoperative pain, bruising, nerve injury, wound infections, and lower rates of deep vein thrombosis compared to HLS.
What about longer term? Does stripping catch up?
Looking out to 5 years, the rates of saphenous trunk recurrence, the treated vein becoming incompetent again, might actually be similar between EVTA and HLS. However, the reason for recurrence is different.
As so.
After EVTA, laser or radiofrequency, recurrence is usually due to recanalization, the treated vein segment partially or completely reopening. After HLS, recurrence is more often due to neovascularization, the formation of new, refluxing veins reconnecting near the site of the original ligation, usually at the groin or popliteal fossa.
And quality of life long term?
Quality of life seems to be equal or potentially better after endovenous treatment compared to HLS, even long term. When compared to modern open surgery, which might incorporate tumescence and phlebectomies, long-term symptoms and quality of life appear similar. Comparing EVLA and RFA themselves, quality of life was similar at 1 and 12 months. But compared to foam sclerotherapy for the trunk, EVLA resulted in better quality of life at 5 years.
Beyond thermal ablation, the guidelines discuss non-thermal techniques. What are these?
These are methods designed to close the incompetent saphenous trunk without using heat energy, thereby aiming to avoid the need for tumescent anesthesia and eliminating the risk of thermal injury to surrounding tissues.
What techniques fall into this category?
The main ones discussed are cyanoacrylate adhesive closure, CFC, medical superglue, essentially, ultrasound-guided foam sclerotherapy, UGFS, when used as a primary treatment for the saphenous trunk itself, not just tributaries, catheter-directed foam sclerotherapy, CDFS, a variation of foam, and mechanochemical ablation, MOCA.
Let's start with cyanoacrylate adhesive closure, the glue. How does it stack up?
It's been compared directly to thermal ablation, RFA, and EVLA. In randomized controlled trials, most notably the VCLOS trial comparing CAC to RFA for great saphenous vein reflux.
What did VCLOS find?
It showed that CAC was non-inferior to RFA in terms of vein closure rates at 36 months, around 94% for CAC versus 92% for RFA, with stable quality of life improvements in both groups. A 5-year extension of a smaller cohort from that trial reported a 93.6% occlusion rate in the CAC group. Another large trial comparing CAC versus EVLA also demonstrated non-inferiority.
What are the pros and cons of glue?
The main advantages are no need for tumescent anesthesia injections and no risk of heat-related nerve injury. Disadvantages include having less long-term follow-up data compared to thermal ablation and a known risk of an inflammatory reaction, phlebitis-like symptoms, in some patients as the body reacts to the glue.
Any other limitations?
Cyanoacrylate is not registered for treating tributaries, only the main trunk, and there's caution advised when using it in very slim patients, as the glue forms a hard polymer which could potentially be felt as a permanent.
What about using ultrasound-guided foam sclerotherapy, UGFS, as the primary treatment for the saphenous trunk?
This is generally considered less effective than thermal ablation, especially for larger veins. Meta-analyses consistently show lower anatomical success rates, typically closure rates between 50% and 80% at 1-3 years, compared to over 90% for EVTA.
Does vein size matter?
Yes, significantly. Foam sclerotherapy is much less likely to achieve durable closure in saphenous trunks larger than about 6 millimeters in diameter. Recanalization rates are higher, and therefore treatment rates are also higher compared to EVT.
Are there complications with foam?
Yes, complications like skin hyperpigmentation, superficial vein thrombosis, SVT, and rare but serious neurological events, like visual disturbances or stroke-like symptoms thought to be related to microbubbles passing through cardiac shunts, can occur. Deep vein thrombosis is also a risk. Foam is often reserved for smaller diameter trunks, tortuous veins difficult to cannulate with a catheter, or situations where thermal ablation is contraindicated or technically challenging.
You mentioned catheter-directed foam sclerotherapy, CDFS. How is that different?
With CDFS, instead of just injecting foam directly, a long catheter is passed up the incompetent trunk under ultrasound guidance, and the sclerosant foam is injected through the catheter as it's withdrawn. Sometimes tumescence is used alongside it.
Is it more effective than standard UGFS for trunks?
A systematic review, including nearly 3,700 patients, suggested it might be. It reported a higher occlusion rate at 3 years for CDFS, 82.4%, compared to standard UGFS, 62.9%. It also seemed to have lower rates of major complications, pain, hyperpigmentation, and SVT compared to UGFS. However, 5-year results are not yet available.
Interesting. And the last non-thermal method, mechanochemical ablation, MOCA, how does that work?
MOCA uses a specialized catheter with a rotating wire at the tip. The wire spins rapidly, mechanically abrading the vein lining, the intima, while simultaneously a liquid sclerosant, like polydocanol or sodium tetracyl sulfate, is injected through the catheter. So it's a combination of mechanical damage and chemical ablation.
How does MOCA compare to thermal ablation?
Randomized controlled trials comparing MOCA versus EVA, both RFA and EVA, have shown it to be safe and effective in the short to medium term, with follow-up reported up to 3 years.
Are the closure rates as good as thermal?
Possibly not quite as high long-term. Occlusion rates seem generally good initially, but one RCT reported lower rates at 3 years compared to thermal ablation, around 80% for MOCA versus nearly 100% for EVLARFA in that study. There seems to be a strong link between failure recanalization at 3 years and larger preoperative. Great saphenous vein diameter. One study showed 100% closure for 6 millimeter veins, but only 75% for 8 millimeter veins with EVLA.
What about symptoms and recovery?
RVCSS scores and quality of life improve significantly after MOCA. Pain during and immediately after the procedure tends to be less with RFA. And similar to EVLA1 trial, return to normal activities is generally quick and similar to thermal methods.
Complications with MOCA.
Common minor issues include temporary induration, SVT, hematoma, deep vein thrombosis risk is low but present. Hyperpigmentation can occur. Importantly, no thermal nerve injury or skin burns have been reported, as no heat is used.
Okay, shifting focus from the main trunks to the smaller veins, C1 disease, those reticular veins and telangiectasias. What's the treatment of choice?
Sclerotherapy is considered the gold standard treatment for these smaller cosmetic veins.
What agents are used?
Usually detergent sclerosants like polidocanol, POL, or sodium tetradicyl sulfate, STS, or sometimes osmotic agents like hypertonic saline or glucose. Success rates are generally high, with studies reporting clearance rates around 95% for POL and 91% for STS.
Are there side effects?
Adverse events are mostly mild and transient. The most frequent are temporary hyperpigmentation, skin staining, matting, development of very fine new vessels near the injection site, and occasionally a small scar at the injection site.
But the guidelines mention a serious warning.
Yes. Critically, they emphasize the rare but devastating complication of inadvertent intra-arterial injection. This can cause extensive skin necrosis, tissue loss, and even limb amputation. It underscores the absolute necessity of performing sclerotherapy, even for these small veins, with extreme care and ideally under careful ultrasound guidance to ensure the needle is definitively within the vein and not an adjacent artery.
Can ultrasound really help avoid arteries when injecting tiny veins?
Yes, particularly by identifying if a small target vein is lying very close to or directly over an artery. One technique mentioned is cannulating the target vein via a connecting visible varix slightly away from the artery if possible.
This importance of careful technique leads to a strong recommendation.
Yes, recommendation 40 is new and clear. For patients with reticular veins, where treatment is planned, sclerotherapy is recommended as the first choice treatment. This is Class 1, Level A, reflecting its established efficacy. But the safety caveats about careful injection technique and considering ultrasound guidance are paramount.
Are there other options for these small C1 veins besides sclerotherapy?
Yes, transcutaneous lasers are an alternative. These target oxyhemoglobin in the blood vessels, converting light energy to heat to close them. Standard vascular lasers like pulsed dye laser, PDL, KTP, Alexandrite diode, and NDYAG are used.
How effective are lasers compared to sclerotherapy?
One study suggested that combining NDYAG laser with foam sclerotherapy was more effective than sclerotherapy alone at 3 months and sustained out to 2-3 years. There's also a newer technique called CLAIR-CS, cryolaser plus cryosclerotherapy plus augmented reality guidance, showing promising results, but it needs more widespread study.
Let's consider some special anatomical situations when planning interventions. What if the main saphenous trunk is unusually large, say over 12 millimeters in diameter?
Historically, there was concern about lower success rates with endovenous techniques in very large veins. However, experience has grown. The guidelines now include a new recommendation, 53. For patients with incompetent great saphenous veins with a very large truncal diameter, 12 millimeter, endovenous thermal ablation should be considered. This is Class I, Level C, indicating it's a reasonable option based on consensus in case series, although high-level evidence is limited. Techniques might need modification, like using higher energy levels or larger volume tumescence.
What if the saphenous trunk is very superficial, very close to the skin, say 5 millimeter deep?
This increases the risk of skin complications, particularly hyperpigmentation or transient induration along the vein tract after treatment, which can sometimes persist but usually resolves. Patients should be counseled about this possibility. Prevention involves optimizing the energy dose for thermal or sclerosant dose concentration for foam to minimize damage.
Can non-thermal methods be used here?
Cyanoacrylate adhesive glue is not registered for tributaries and should be used with caution for very superficial trunks, especially in slim patients, due to the risk of a palpable, potentially permanent cord. Phlebectomy, surgical removal of the superficial segment, might be a good alternative in these cases.
What if the trunk has internal changes from previous SVT or failed sclerotherapy, like old thrombus or fibrosis?
This can definitely make navigating devices like laser fibers or radiofrequency catheters more difficult or even impossible. Pre-treatment duplex ultrasound is mandatory to assess this. The cannulation strategy might need to be adapted, VerG accessing higher or lower than usual. If standard cannulation fails, UGFS, perhaps via direct injection or using a short cannula, might be an alternative way to treat the incompetent segment.
What about saphenous trunk aneurysms? Are they common?
No, they're rare. Defined as localized dilation more than 3 times the average diameter, or specifically 20 millimeters at the saphenofemoral junction or 15 millimeters at the saphenopopliteal junction. They can be complicated by thrombosis and rarely pulmonary embolism.
How are they treated?
Historically, open surgical repair was the standard. However, a recent small study suggested that EVTA alone, or sometimes combined with high ligation if the aneurysm is very large, 6L 30 millimeters at the SFJ, can be safe and effective. More data is needed, but endovenous approaches are being explored.
Okay, let's pause and recap interventions for superficial disease. Endovenous techniques are now standard, preferably outpatient under tumescent anesthesia, class 1C. Buffered tumescence helps pain, class IOB. Post-op compression should be considered classified A.
Right. EVTA is generally superior to HLS short-term. Class 1A level evidence supports intervention for C2. Recurrence causes differ. Recanalization post-EVTA versus neovascularization post-HLS.
Non-thermal options like glue, sac, foam, UGFS, CDFS, and MOCA are alternatives, each with pros and cons. CAC is non-inferior to RFA short-term, but has less long-term data and phlebitis risk. UGFS for trunks has lower efficacy, especially in large veins. CDFS might be better than UGFS. MOCA is promising, but may have lower long-term occlusion than EVTA, especially in larger veins.
Sclerotherapy is the gold standard for C1 veins, class 1A, but requires extreme care and ideally ultrasound guidance due to rare but severe arterial injection risk. Lasers are an alternative for C1.
Special anatomies need tailored approaches. EVTA should be considered for very large trunks, 12 mm, class 3IC. Caution with very superficial trunks. Risk of skin issues, phlebectomy alternative. Adapt strategy for intraluminal changes. Endovenous options emerging for aneurysms.
For you in practice, this highlights the importance of detailed duplex mapping for planning. You need to understand the strengths, weaknesses, evidence level, and specific technical considerations for each endovenous modality, thermal, glue, foam, MACA, to choose the best approach for the individual patient's anatomy and preferences. And that safety message for sclerotherapy cannot be overstressed.
Absolutely. Now let's tackle a common clinical headache. Recurrent varicose veins after previous treatment.
Yes, recurrence is unfortunately quite frequent, and understanding why it happened is the absolute key to planning effective treatment. The guidelines categorize the causes clearly.
What are the main reasons veins come back?
You can broadly group them. First, technical failure of the initial procedure, maybe incomplete stripping, inadequate ablation, or failure to address all sources of reflux initially. Second is neovascularization, the growth of new refluxing veins typically seen at the groin, saphenofemoral junction, or popliteal fossa after previous surgical ligation and stripping.
And the third?
Recanalization. This is when a segment of a previously treated vein, usually one that was ablated using endovenous techniques, thermal or non-thermal, reopens and starts refluxing again.
And finally, simple disease progression.
Exactly. The venous disease itself is progressive. New sources of reflux can develop over time in segments that were previously normal. Maybe the other saphenous trunk, the anterior accessory or small saphenous vein, or new incompetent perforating veins. So recurrence isn't always a failure of the first treatment. It could just be the natural history of the disease.
Does knowing the cause change the treatment approach?
Absolutely. Historically, the approach to recurrence, especially after surgery, often involved redo open surgery going back into the groin or popliteal fossa through scar tissue.
But the guidelines strongly advise against that now.
Very strongly. Redo open dissection in a previously operated field is technically challenging, takes longer, and carries significantly higher risks of complications like nerve damage, lymphatic leakage, lymphorrhea, and wound infections. It should be avoided whenever possible.
So what's a preferred strategy for recurrence?
A less invasive approach, guided by detailed duplex ultrasound mapping to precisely identify the sources of the recurrent reflux. Treatment should target that specific source using techniques like endovenous ablation, thermal or non-thermal, of a refluxing residual or newly incompetent trunk, ultrasound-guided foam sclerotherapy for networks of veins or neovascularization, or ambulatory phlebectomies for removing visible varicosities. The key is to do this without surgically re-exploring the groin or popliteal fossa, if at all possible.
Are these less invasive approaches effective?
Yes, studies show they are as effective as redo open surgery in managing recurrence, but are considerably safer.
This leads to a very clear recommendation against routine redo surgery.
Yes, recommendation 56 is firm. Redo surgical exploration of the groin or popliteal fossa should not be performed for recurrent varicose veins if less invasive treatments are feasible. This is graded class 3, harm, level B. It's not just not useful, it's potentially harmful and should be avoided if alternatives exist.
What if the recurrence involves only tributaries or neovascular tissue without a major incompetent trunk?
There's a new recommendation for that scenario too, recommendation 57. For patients with symptomatic recurrent varicose veins without truncal incompetence, ultrasound-guided foam sclerotherapy and/or ambulatory phlebectomy should be considered. This is class 2A, level C, supporting these targeted, minimally invasive options for localized recurrences.
So the takeaway for you dealing with recurrent varicose veins, first step always is detailed duplex ultrasound mapping to understand the precise anatomy and hemodynamics of the recurrence. Second, choose the least invasive, targeted treatment based on those findings, EVTA, foam, phlebectomy, and explicitly avoid redo open groin or popliteal surgery whenever feasible due to the higher risks.
That's the modern approach, exactly.
Okay, let's pivot now from the superficial system to interventions for deep venous pathology. This feels like a significantly different area in terms of complexity and treatment goals.
It absolutely is. We're talking about problems within the main drainage pipes of the deep veins. Issues here, whether it's reflux, obstruction, or both, often cause much more severe symptoms and signs, falling under the umbrella of chronic venous insufficiency.
What's the first line of treatment for deep vein issues?
Always non-invasive conservative management, primarily adequate compression therapy, along with exercise and lifestyle measures.
When are interventions considered?
Only if conservative measures fail to provide sufficient relief and the patient continues to have significant symptoms impacting their quality of life. And critically, intervention requires appropriate assessment and confirmation of clinically significant deep venous reflux or obstruction that is amenable to treatment.
Who are the main patients considered for deep vein interventions?
The largest group consists of patients suffering from post-thrombotic syndrome, PTS, following a previous deep vein thrombosis. Another important group include patients with symptomatic non-thrombotic iliac vein lesions, NIVL, typically compression syndromes like May-Thurner.
Let's quickly revisit post-thrombotic syndrome.
PTS is defined as the complex of symptoms and signs that can develop in a limb following a deep vein thrombosis, resulting from impaired venous outflow due to residual obstruction and a secondary valve incompetence, reflux.
What are the typical features?
Symptoms include chronic leg pain, heaviness, fatigue, itching, cramping, and sometimes venous claudication. Signs can range from tenderness on calf compression, varicose veins secondary, persistent edema, skin changes, pigmentation, eczema, lepidermatosclerosis, and ultimately venous-led ulceration. It can progress or worsen over time.
How common is PTS?
It's estimated to occur in 20% to 50% of patients after a proximal deep vein thrombosis, with 5% to 10% developing severe PTS, often including ulceration.
When does it typically develop?
Usually within 3 to 5 years after the initial deep vein thrombosis, although sometimes later. The diagnosis is generally made only after at least 3 months have passed since the acute event to differentiate PTS from the resolving symptoms of the acute deep vein thrombosis itself. It significantly impacts quality of life and healthcare costs.
Are there factors that increase the risk of developing PTS?
Yes, several risk factors have been identified. Increased BMI, obesity, older age, smoking, pre-existing superficial venous incompetence, the location of the initial deep vein thrombosis, iliofemoral yoke carries higher risk, recurrent deep vein thrombosis in the same leg, persistent symptoms or signs at 1 month after the acute event, evidence of residual venous obstruction on imaging, persistent D-dimer elevation, and subtherapeutic anticoagulation during initial treatment.
Can PTS be prevented?
Prevention strategies focus on optimizing anticoagulation for the initial deep vein thrombosis, potentially considering early thrombus removal, like catheter-directed thrombolysis, in selected cases of extensive iliofemoral deep vein thrombosis, and importantly, recommending adequate below-knee elastic compression stockings after the acute phase.
And treatment for established PTS?
As we said, conservative measures are the first option. Supervised exercise programs, appropriate compression therapy, usually below-knee stockings, and potentially venoactive drugs, as discussed earlier. Invasive treatment options, endovenous or surgical, are reserved for carefully selected patients whose symptoms remain severe despite optimal conservative care.
A general principle for invasive deep vein work mentioned in the guidelines.
Yes, due to the complexity, the potential risks, and the significant learning curve involved, these interventions are best performed in specialized centers with high expertise and case volume.
What about anesthesia for deep vein interventions?
It depends on the procedure. Endovascular recanalization and stenting, especially of chronic post-thrombotic lesions, can be painful. For relatively straightforward non-thrombotic iliac vein lesion stenting like May-Thurner, conscious sedation combined with intravenous analgesia may be sufficient. However, for more complex procedures involving recanalization of chronic fibrotic post-thrombotic occlusions, general anesthesia is often required.
Let's focus specifically on treating deep venous obstruction, often with endovascular recanalization and stenting, typically in the iliac veins. What do the guidelines say about the evidence here?
They are quite cautious and highlight the significant challenges in interpreting the available literature. There's marked heterogeneity across trials and reports in terms of patient populations, mixing non-thrombotic iliac vein lesions with chronic post-thrombotic occlusions, lesion types, stenosis versus occlusion, classification systems used, treatment criteria, imaging protocols, and outcome measures. This makes drawing firm conclusions difficult, and the overall quality of data is often considered weak.
Despite these limitations, are there any consistent findings?
Yes. Patency rates after stenting for non-thrombotic iliac vein lesions are generally very good, approximating 95–100% in many series. This is considerably better than patency rates after recanalization and stenting for chronic post-thrombotic occlusions, which typically range from 70–80% at follow-up periods beyond 6 months. The quality of the inflow vessels below the stented segment seems to be a major determinant of long-term patency in post-thrombotic cases.
What about clinical outcomes after stenting for obstruction?
This is harder to appraise consistently due to varied reporting. Reductions in RVCSS and Villalta scores are commonly reported. However, less specific outcomes like edema relief or symptom alleviation lack objective definition. VLU healing rates post-stenting vary widely in reports, 56–100%, as do recurrence rates, 0–17%. Quality of life generally seems to improve after successful intervention, though different scoring systems are used.
Are the newer dedicated venous stents better than older stents used off-label?
The guidelines state there's currently no reliable data suggesting superiority of the newer on-label venous stents compared to previously used stents like wall stents, specifically for treating chronic venous obstruction in terms of long-term performance. More studies are needed.
So what's the overall conclusion on endovascular treatment for deep obstruction?
Despite the study limitations and potential biases, the guidelines conclude that the available evidence does support a role for endovascular treatment, stenting, in patients with chronic venous outflow obstruction, provided that patient selection is appropriate and conservative measures have failed.
What about reintervention after iliac stenting? Is it common?
It can be. Careful patient selection for the primary procedure, considering anatomical factors, patient factors like hematological conditions, is crucial to minimize complications that might necessitate reintervention. Stent occlusion remains a significant problem, particularly in advanced disease, and repeat interventions can be challenging.
Should asymptomatic instant restenosis be treated?
This is controversial. There's a lack of evidence showing that intervening on asymptomatic narrowing improves long-term outcomes or prevents future thrombosis. For symptomatic restenosis, conservative measures or extending anticoagulation are valid options alongside reintervention.
What are the options for reintervention if needed?
The vast majority are for acute stent thrombosis or symptomatic instant stenosis. Acute thrombosis within a stent is managed similarly to primary acute deep vein thrombosis, often involving consideration of early thrombus removal strategies, pharmacomechanical thrombectomy, catheter-directed thrombolysis, especially if symptoms are severe. These should be done in experienced centers.
And after clearing the thrombus?
It's imperative to adequately treat the underlying obstructive lesion, the stenosis or compression that led to thrombosis, to prevent recurrence. Trying to recanalize a stent that has been occluded for more than about 2 weeks is often technically difficult and unlikely to result in durable patency.
Is there a recommendation regarding imaging during these procedures?
Yes, recommendation 59 is new. For patients with iliac vein outflow obstruction undergoing endovascular treatment, the use of intravascular ultrasound, IVUS, should be considered to guide treatment. This is Class 2, Level C, reflecting expert consensus that IVUS provides valuable real-time information about lesion severity, vessel diameter, stent placement, and expansion, potentially improving outcomes.
What if endovascular options fail or aren't suitable? Is there a role for surgical reconstruction or hybrid procedures?
Their role is very limited due to a lack of strong evidence. They're generally considered only in exceptional cases involving major disease burden, severe symptoms like recalcitrant ulcers, severe PTS, disabling venous claudication, and where purely endovascular options are not appropriate or have failed. Endovascular treatment is always the preferred first option if feasible.
What kind of surgical or hybrid procedures are mentioned?
Hybrid approaches might involve open surgical endophlebectomy, removing the obstructing scar tissue from a segment like the common femoral vein, combined with endoluminal stenting of adjacent segments. Limited case series suggests this can improve symptoms and quality of life, and it has been recommended for healing refractory venous ulcers, but there are no RCTs. The guidelines conclude that a substantial recommendation for or against endophlebectomy isn't possible based on current evidence. It's reserved for highly selected patients in expert centers.
What about purely surgical bypasses or reconstructions?
Options for bypassing occluded femoral popliteal veins are extremely limited. The May-Husny procedure is described, where the ipsilateral great saphenous vein is transposed to bypass femoral outflow obstruction, rerouting flow down the saphenous vein. While one study showed potential benefits from femoral popliteal recanalization techniques, stronger evidence is needed before such complex surgical reconstructions can be recommended routinely.
How is this limited role reflected in the recommendations?
Recommendation 60 has been changed. For patients with iliac vein outflow obstruction, suffering from a recalcitrant venous leg ulcer, severe post-thrombotic syndrome, or disabling venous claudication, surgical or hybrid deep venous reconstruction may be considered when endovascular options alone are not appropriate. This is a Class IAB, Level C recommendation. It signifies less well-established usefulness reserved for these specific severe situations based on consensus opinion.
What about anticoagulation after iliac vein stenting?
This is a major area of debate and uncertainty. Lifelong anticoagulation is often recommended in practice, particularly after stenting for post-thrombotic disease. However, the guidelines explicitly state there is a lack of robust evidence to guide specific strategies regarding the optimal duration, the choice of agent, DOACs versus vitamin K antagonists versus antiplatelets, or the intensity of treatment. Practice varies widely.
Any evidence on VTE prophylaxis during or immediately after the procedure itself?
Use of intermittent pneumatic compression or early mobilization may reduce complications, but specific evidence is scarce. For stenting performed for non-thrombotic iliac vein lesions, the guidelines state that no particular antithrombotic strategy can be recommended due to the lack of evidence.
Are there significant safety concerns with deep vein interventions?
Perioperative death or pulmonary embolism are extremely rare, based on sparse reports. A large study looking at nearly 4,000 stented limbs reported an overall complication rate of around 3%.
What kind of complications?
These include access site hematoma, stent migration or fracture, iliac vein rupture, rare but serious, stent thrombosis, and notably, contralateral deep vein thrombosis. Reported rates vary from 0% to 15.6%. Contralateral DVT usually occurs when a stent extends into the inferior vena cava, potentially jailing or obstructing flow from the opposite iliac vein.
Given all this complexity, teamwork seems important.
Absolutely. Recommendation 63 is new and emphasizes this. For patients with iliac vein outflow obstruction, management by a multidisciplinary team is recommended. This is Class I, Level C, consensus supporting the input of vascular surgeons, interventional radiologists, hematologists, and potentially others in making decisions for these complex patients.
Okay, let's summarize deep vein obstruction intervention. Conservative care first. Intervention only for selected patients with significant symptoms despite conservative care, PTS, and IVL. Endovascular stenting is the main approach, with better patency for NIVL than post-thrombotic disease.
Right. Evidence quality is limited by heterogeneity. IVUS guidance should be considered OIAC. Reintervention for stent thrombosis stenosis is common. Treating asymptomatic stenosis is controversial.
Surgical or hybrid reconstruction has a very limited role, may be considered only for severe refractory cases where endo options fail, IIAC. Optimal post-stenting anticoagulation strategy remains unclear due to lack of evidence. A multidisciplinary team approach is recommended, IC.
For you managing these patients, this is complex territory requiring specialized expertise. Patient selection needs to go beyond just imaging, incorporating symptom severity like claudication and impact on life. Multidisciplinary discussion is key. Be prepared for the possibility of reintervention and manage patient expectations accordingly.
Now, let's briefly touch on interventions specifically for deep venous incompetence, DVI, meaning reflux in the deep system distinct from obstruction.
Yes, this is treated even less commonly than obstruction. Surgical treatment may be considered, but only under very specific circumstances.
What are those circumstances?
Conservative management must have failed. The patient must have persistent severe symptoms or signs related to the deep reflux, and crucially, there must be no significant outflow obstruction, or any obstruction must have been successfully corrected previously.
Is all deep reflux treatable surgically?
No, patient selection is very strict. Generally, only axial reflux, meaning reflux extending downwards from the thigh veins, across the popliteal vein, and into the calf veins, is considered potentially suitable for surgical intervention.
How is it diagnosed?
Duplex ultrasound is the initial tool, but descending venography can be useful to confirm the presence and extent of axial reflux when planning intervention.
What are the surgical options?
Techniques like direct valve repair, valvuloplasty, or transposing a segment of vein containing a competent valve, like from the profundifemoris vein to the superficial femoral vein, are described. These are complex procedures performed rarely, even in specialized centers.
What about patients who have both superficial incompetence and deep venous incompetence, combined reflux?
This is a common scenario. The important point here is that you can always treat the superficial reflux component. In fact, studies show that in up to 50% of cases with combined superficial and deep reflux, simply treating the incompetent superficial veins, for example, ablating the saphenous vein, can lead to correction or significant improvement of segmental deep venous reflux.
So treating the superficial helps the deep.
It often does. Clinical scores like RVCSS improve substantially after treating incompetent saphenous veins, even when deep reflux is also present.
What if there's superficial reflux and deep vein obstruction?
Then you need to be cautious. Rarely, the refluxing great saphenous vein might be acting as an important collateral pathway, helping drain the leg around the deep obstruction. Before ablating it, you need to carefully evaluate its role in limb drainage, usually with experienced duplex ultrasound assessment or sometimes venography. If it's deemed essential, ablation might be contraindicated.
So for DBI, surgery is rare, highly selective for axial reflux without obstruction after conservative failure. In combined superficial deep reflux, always treat superficial first. It often helps the deep component. If deep obstruction is also present, check if the GSV is a needed collateral before ablating it.
Precisely.
Let's make a quick mention of popliteal vein entrapment syndrome, PVES.
Yes, the guidelines include it briefly under deep venous pathology. It's a less common cause of venous hypertension symptoms.
How does it present?
Patients typically have symptoms and signs of chronic venous disease, pain, swelling, sometimes skin changes, but often without the usual findings of superficial or deep reflux or obstruction on standard duplex. Although chronic entrapment can eventually lead to popliteal vein thrombosis.
How is it diagnosed?
Diagnosis often involves dynamic testing, measuring pressure in the popliteal vein, or observing flow changes with provocative maneuvers like active plantar flexion or knee extension, which compress the vein. One study noted significantly higher popliteal compartment pressures during knee extension in PVES patients compared to controls.
Is there an association with body type?
Yes, it seems to be associated with higher BMI, possibly because a larger popliteal fat pad contributes to the extrinsic compression of the vein within the tight popliteal space.
So PVES is a differential to consider for unexplained venous symptoms, especially if standard duplex is normal.
Exactly. It requires specific diagnostic maneuvers or pressure measurements to confirm.
Okay, now let's transition to a major clinical challenge. The management of active venous leg ulceration, VLU, CEAP class C6.
VLUs represent the most severe manifestation of chronic venous disease and carry a huge burden for patients and healthcare systems, largely due to their tendency to recur.
How high is the recurrence rate?
Shockingly high. Studies report recurrence rates up to 70% within just 3 months of initial healing. This really underscores the need for comprehensive, organized, and cost-effective management strategies that focus not just on healing the current ulcer, but critically on preventing it from coming back.
What's the recommended approach to care?
Specialist care, ideally within a multidisciplinary team setting involving vascular specialists, wound care nurses, dermatologists, etc., is associated with better outcomes. A systematic approach to local wound care is essential. The TIME concept is mentioned as a useful framework.
Can you remind us what TIME stands for?
T is for tissue assessing and managing non-viable or deficient tissue in the wound bed. I is for infection or inflammation control. M is for moisture balance managing, exudate appropriately. And E is for edge of the wound, assessing and stimulating epithelial advancement from the margins. While the TIME framework itself lacks specific RC2 validation as a concept, its principles are widely adopted for guiding wound bed preparation.
What specific local wound care strategies are discussed?
Mobilization and physical therapy are encouraged, aiming to activate the calf muscle pump and reduce edema. However, the guidelines note that direct evidence showing these measures significantly improve VLU healing rates or reduce recurrence is currently scarce.
What about cleaning the wound bed?
Wound bed preparation aims to convert the chronic, non-healing wound environment towards one that supports acute healing. This starts with cleansing and usually involves debridement, the removal of necrotic tissue, slough, debris, and foreign bodies.
What methods of debridement are used?
Various methods exist. Surgical or sharp debridement, using scalpel or curette, mechanical debridement like washing, hydrotherapy, wet-to-dry dressings, ultrasound-assisted debridement, autolytic debridement, using dressings that promote the body's own enzymes, enzymatic debridement using topical agents, and biological debridement using sterile maggots.
Once the wound is clean, what about dressings and topical agents? There's so many available.
An overwhelming number. However, a major Cochrane review, including 59 RCTs and over 5,000 participants, concluded that more research is needed. There is currently insufficient high-quality evidence to determine whether any specific type of dressing or topical agent is superior to others in terms of improving VLU healing rates.
So the choice of dressing is more about wound characteristics.
Exactly. Specific dressings are useful for managing particular wound characteristics, like high exudate levels using absorbent dressings, or maintaining a moist environment. But none have been definitively proven to accelerate healing better than simple, inexpensive, non-adherent dressings when used under adequate compression.
Any other local therapies?
Hyperbaric oxygen therapy lacks reliable evidence for VLU. Therapeutic ultrasound's effect on healing is unclear based on a review of 11 studies. Any effect is likely small. Electromagnetic therapy effects are also not established by high-quality RCTs due to study heterogeneity.
So local wound care is important, but the real cornerstone of VLU management is
Compression therapy, absolutely essential.
what type and level of compression is recommended for active VLUs, C6?
The guidelines are clear. High-pressure compression, generally aiming for greater than 40 mmHg at the ankle, should be applied. And importantly, inelastic materials, like multi-component, multi-layer bandage systems or adjustable compression garments, are generally preferred over purely elastic systems for active ulcer treatment.
Why inelastic over elastic for ulcers?
Studies have shown that inelastic compression systems are more effective than elastic ones at reducing venous reflux, increasing calf muscle pump function, and improving overall venous hemodynamics during walking. They provide a high working pressure when the patient moves, but a lower resting pressure.
Are there alternatives if high-pressure inelastic bandages aren't feasible?
For smaller ulcers, one RCT involving over 450 participants showed that superimposed elastic compression stockings, achieving 40 mmHg, were a good alternative to standard 4-layer inelastic bandages, resulting in similar median healing times, around 99 days.
But the safety check is paramount before applying any high compression.
Absolutely non-negotiable. An ABI measurement is mandatory before applying high compression therapy for a VLU to exclude significant peripheral arterial disease. ABI 0.6 is a contraindication.
What about mixed arterial venous ulcers?
If there's coexisting arterial disease but it's less severe, for example, systolic ankle pressure 60 mmHg, reduced levels of compression less than 40 mmHg may be used, but only under very close monitoring and specialist supervision.
Can intermittent pneumatic compression, IPC, be used for ulcers?
Yes, IPC can be considered as an adjunct to standard compression if healing is slow, or as an alternative if other forms of compression are not available, not tolerated, or ineffective. This is a Class 3A, Level B recommendation.
Beyond compression and local care, what about treating the underlying venous problem that caused the ulcer?
This is critical for both healing and preventing recurrence. Addressing the source of the venous hypertension is key.
If the ulcer is due to superficial venous incompetence,
Then intervention is strongly recommended. The EVRA trial showed that early endovenous ablation of incompetent superficial veins performed alongside compression therapy significantly accelerates ulcer healing compared to compression alone.
so treat the veins early.
Yes. Recommendation 76 is new and reflects this. For patients with an active venous leg ulceration and superficial venous incompetence, early endovenous ablation is recommended to accelerate ulcer healing. This is Class I, Level B.
What about after the ulcer has healed? Should the veins still be treated?
Yes, definitely, to reduce the high risk of recurrence. The eShort trial compared compression alone versus compression plus surgery, performed after a median of 7 weeks, for patients with active or recently healed ulcers. While surgery didn't significantly speed up healing in that trial, it dramatically reduced ulcer recurrence rates at 4 years. 31% recurrence in the surgery group versus 56% in the compression alone group.
So another strong recommendation here.
Yes, recommendation 77 is also new. For patients with superficial venous incompetence and healed venous leg ulceration, treatment of the incompetent veins is recommended to reduce the risk of ulcer recurrence. Also Class I, Level B.
What if the patient has both superficial incompetence and deep venous incompetence? Should you still treat the superficial veins?
Yes, the guidelines explicitly state, recommendation 79, new. In patients with active or healed venous leg ulceration, superficial veins should be treated even in the presence of deep venous incompetence. This is Class I, Level C, consensus. Fixing the superficial component is beneficial regardless of deep reflux.
What about incompetent perforating veins in VLU patients? Should they be treated routinely?
This remains an area of controversy and variation in practice. Incompetent perforators are common in C6 disease, usually alongside saphenous trunk reflux. However, major trials like ESHAR and EVRA primarily focused on treating the truncal reflux without specific perforator intervention.
So, no clear evidence for routine perforator treatment.
Correct. No randomized controlled trials have demonstrated an additional benefit from routinely treating incompetent perforators at the same time as treating saphenous incompetence in VLU patients. One long-term study did associate persistent incompetent perforators with ulcer recurrence, but routine intervention isn't universally recommended. Experience with endovenous perforator treatment near diseased skin is still limited.
What if the ulcer is related to deep vein pathology, like iliac obstruction?
This adds complexity. Venous ulcers can involve superficial, deep, or pelvic sources of hypertension or combinations. Determining the best strategy can be challenging.
Is there evidence for treating deep obstruction in VLU patients?
Yes, accumulating evidence suggests it's beneficial. A prospective cohort study using an algorithm based on saphenous reflux and iliac obstruction found good long-term healing rates, 75% at 5 years, whether patients had superficial ablation alone, stenting plus ablation, or stenting alone. Residual deep reflux didn't seem to impact healing.
Any other
Another retrospective cohort found that combining iliac stenting with EVLA in patients with iliac compression significantly reduced VLU prevalence compared to EVLA alone. A systematic review of iliac stenting reported an overall VLU healing rate of 71%, while an RCT comparing stenting versus conservative care included too few C6 patients for firm conclusions on ulcers specifically. The trend supports intervention.
So, what's the recommendation for deep obstruction in VLU?
Based on this evidence, recommendation 81 is new. For patients with active or healed venous leg ulceration and iliac vein outflow obstruction, venous stenting should be considered. This is Class CLA, Level B.
What about surgery for deep reflux, DVI, affecting VLU healing?
The guidelines state there is currently no data available on the effect of surgery for DVI on venous leg ulcer healing.
Are there any medications that can help VLU healing?
Yes, certain venoactive drugs have been investigated as adjuncts to compression and local care. MPFF, micronized purified flavonoid fraction, showed in a meta-analysis a statistically significantly higher chance of VLU healing at 6 months, about 32% more frequent, compared to placebo when added to standard care. Cochrane reviews found similar positive results, though noted some methodological issues.
So VADs can be helpful adjuncts.
It appears so. Recommendation 82 is unchanged from 2015. For patients with active venous leg ulceration, micronized purified flavonoid fraction, hydroxyethylruticides, pentoxifenolide, or sulodexide should be considered as an adjunct to compression and local wound care to improve ulcer healing. This is Class IL Level A, indicating good evidence supports considering these specific agents.
Let's try to summarize the overall VLU management strategy.
It needs to be multidisciplinary and comprehensive. Address underlying patient risk factors like poor mobility, ankle stiffness, and especially obesity. Exercise and weight loss are key. Treat the underlying pathophysiological cause of the venous hypertension whenever feasible, usually incompetent superficial veins or iliac obstruction.
And if the underlying cause can't be fixed?
That optimize conservative care, primarily compression and leg elevation. Assessment must include pain management, consideration of adjunctive pharmacotherapy, VADs, and appropriate local wound care based on the time principles.
A major challenge mentioned is access.
Yes, ensuring patients have access to appropriate diagnostics, especially duplex ultrasound, and specialist procedures remains a challenge, particularly in community care settings, which are often undersupported.
And prevention is key.
Absolutely. Educating patients with healed ulcers about lifelong compression compliance and ensuring they receive appropriate treatment for their underlying chronic venous disease is crucial to prevent recurrence. Healthcare professionals also need ongoing education on best practices, and that mandatory ultrasound evaluation is the linchpin guiding the entire strategy.
Okay, quick VLU recap. High recurrence needs focus on prevention. Multidisciplinary care using time for local management. Compression is essential. High pressure 40 mmHg, Hg, inelastic preferred, mandatory ABI check.
Intervene early on superficial incompetence to accelerate healing, Class 1. Treat superficial incompetence in healed ulcers to reduce recurrence, Class 1B. Treat superficial even if deep reflux exists, Class 1C. Perforator treatment remains controversial.
Consider stenting for iliac vein obstruction if present. Class IB. Consider specific VADs, MPFF, HR, pentoxifenolide, sulodexide as adjuncts to aid healing, Class IOA. And mandatory ultrasound guides the plan.
For you managing VLUs, think beyond just the wound. Get the duplex, identify the underlying venous drivers, and address them proactively with intervention alongside optimal compression and holistic care. Collaborate with your wound care team.
Great. Let's move on to another challenging area. Pelvic venous disorders, PVD, that cause lower limb varicose veins.
Yes, this area has historically suffered from confusing terminology.
Yeah.
May-Thurner syndrome, pelvic congestion syndrome, nutcracker syndrome, often used interchangeably or vaguely. The guidelines highlight the need for clarity.
Is there a new classification system?
Yes, they introduced the SVP classification, standing for symptoms versus pathophysiology. It's designed to be used alongside the standard CEAP classification and describes findings across 4 anatomical zones. Zone 1, left renal vein area. Zone 2, gonadal veins, internal iliac veins, pelvic plexuses. Zone 3, pelvic origin extrapelvic veins like vulvar, perineal, gluteal. And Zone 4, lower extremity deep and superficial veins affected by pelvic sources.
What kind of pelvic pathologies can lead to lower limb varicose veins?
Pelvic venous incompetence, allowing reflux down into the legs, is often secondary to outflow obstruction or compression higher up. The classic example is compression of the left common iliac vein by the overlying right common iliac artery, often called May-Thurner physiology.
What else can cause it?
Compression of the left renal vein between the aorta and superior mesenteric artery, nutcracker phenomena, can cause high pressure in the left renal vein, leading to reflux down the left gonadal vein into the pelvis and potentially the legs. Post-thrombotic obstruction of the iliac veins, or IVC, can also cause pelvic venous hypertension and secondary reflux. Extrinsic compression from pelvic masses or endometriosis is another possibility.
Are these compression syndromes common?
Anatomical compression itself is surprisingly common. Significant narrowing, 50% area reduction, of the left common iliac vein is found in 25–33% of the general population on imaging, and significant left renal vein compression in 51–72%. However, most people with these anatomical findings are completely asymptomatic.
So only some develop problems.
Yes, only a subset develop symptoms like chronic pelvic pain in women, leg edema, venous claudication, or even venous ulcers from CIV compression, or left flank pain and hematuria from LRV compression.
How do these pelvic issues cause leg varicose veins?
Pelvic venous hypertension finds escape points pathways of least resistance for blood to reflux out of the pelvis. These commonly include veins in the perineum, vulva in women, buttocks, sciatic veins, and proximal medial thigh. These incompetent escape point veins can then cause visible varicose veins in atypical locations, or sometimes feed into and cause reflux in the typical saphenous trunks.
How often are leg varicose veins actually caused by a pelvic source?
Estimates suggest that non-saphenous reflux, originating from a pelvic source, accounts for perhaps 3–4% of limbs presenting with chronic venous disease symptoms or signs. It's thought to be more common during or after pregnancy and in patients with recurrent varicose veins after previous treatment of saphenous sources. Chronic pelvic pain is reported in less than 10% of patients found to have varicose veins originating from pelvic venous incompetence.
How should these patients be assessed clinically?
If a female patient presents with chronic pelvic pain and there's suspicion of PVD, the first step is to exclude other gynecological or non-gynecological causes of pelvic pain. That's a Class 1, Level C recommendation.
What about investigating the leg veins and potential pelvic connection?
Specific duplex ultrasound examination targeting those potential pelvic escape points, perineal, inguinal, gluteal regions, is recommended in patients presenting with symptomatic varicose veins that appear atypical or might originate from the pelvis. This is also Class 1, Level C.
Should abdominal or pelvic ultrasound be done?
Abdominal and/or transvaginal duplex ultrasound should be considered in female patients with suspected pelvic venous disorders, Class ISC Level C. As discussed earlier, this looks for dilated ovarian veins, 5 mm, or internal iliac veins, and assesses flow patterns, continuous versus intermittent reflux, to hint at underlying causes. Remember the limitations of DUS here: obesity, bowel gas, operator expertise.
When is venography needed?
Selective venography, often combined with cross-sectional imaging, CT or MR venography, remains the gold standard for confirming pelvic venous incompetence and mapping the reflux pathways. It is considered essential before performing pelvic vein embolization. IVUS can also be used during venography to assess for underlying iliac compression.
How is management decided? It sounds complex.
The management strategy critically depends on whether the patient has significant pelvic symptoms, mainly chronic pelvic pain that impacts their quality of life, in addition to the lower limb varicose veins.
What if they have varicose veins clearly originating from the pelvis, but no pelvic pain or other pelvic symptoms?
In this situation, the guidelines recommend treating the lower limb problem first. Local procedures targeting the visible varicose veins and the pelvic escape points using techniques like foam sclerotherapy, phlebectomy, or sometimes surgical ligation of the escape points are considered the useful first option.
Why not just embolize the pelvic veins?
Because it might be unnecessary overtreatment if the patient has no pelvic symptoms. The recommendation, 87 new, is quite strong. For patients with varicose veins of pelvic origin without pelvic symptoms, pelvic vein embolization should not be performed as the initial treatment. This is class 3, harm no benefit. Level C embolization should only be considered in this group if the local procedures fail, the varicose veins recur very quickly, or if the patient subsequently develops pelvic symptoms.
Well, what if the patient does have significant pelvic symptoms, like chronic pelvic pain related to the pelvic venous incompetence, as well as the leg varicose veins?
Then targeting the pelvic source becomes the primary goal. Percutaneous endovenous embolization of the incompetent gonadal veins, usually ovarian, sometimes internal iliac veins as well, is considered the current standard therapy for chronic pelvic pain associated with pelvic venous incompetence.
Is embolization effective for pelvic pain?
Studies report high technical success rates, 96 to 100%, and significant improvement in pelvic pain symptoms, although recurrence of pain can occur in up to 32% of patients over time. Complications are generally rare and non-fatal.
So there's a recommendation supporting embolization in this group.
Yes, recommendation 88 is new. Pelvic vein embolization should be considered in patients with varicose veins of pelvic origin with pelvic symptoms. This is class 30 AEL level B, reflecting evidence supporting its use for symptomatic relief.
Should local treatment of the leg veins still be done in these symptomatic patients?
Yes, local procedures targeting the varicose veins or related pelvic escape points should also be considered. Recommendation 86, new, class 3A level C. Treating both the source, pelvic reflux, and the manifestation, leg varicosities, may provide the best overall outcome.
The guidelines include a flowchart summarizing this strategy.
Yes, figure 15, essentially. Non-pregnant patient with symptom signs suggesting PVD perform duplex, abdominal transvaginal escape points. If pelvic source identified and D pelvic symptoms are present, consider pelvic vein embolization and local leg treatment. If pelvic source identified but NO pelvic symptoms, treat leg veins escape points locally first. If local treatment fails or symptoms develop, then consider pelvic vein embolization. If complex anatomy like significant ileocrenal compression is found, consider stenting or other alternatives. Conservative options, compression, hormonal therapy for pain, are also alternatives for symptomatic patients.
Okay, summarizing PVD causing VDs. Use the new SVP classification. Remember, CIVLRV compression is common anatomically but often asymptomatic.
Exclude other causes of pelvic pain first, class 1C. Use Duplex to assess escape points, class 1C, and consider abdominal transvaginal duplex, class 5IC. Venography plus CTMR is essential before embolization.
Management hinges on pelvic symptoms. If and no pelvic symptoms, treat leg veins escape points locally first, do not embolize initially, class 3C. If pelvic symptoms are present, consider pelvic vein embolization, class 3AB, and also consider local leg vein treatment, class 3C.
For you managing patients with atypical varicosities, recurrence after standard treatment, or concurrent pelvic pain, keep PVD on your differential. Investigate methodically using duplex and selective imaging when indicated. Tailor the intervention, local versus pelvic embolization, based primarily on the presence or absence of significant pelvic symptoms, not just the finding of pelvic reflux on imaging.
Excellent. Let's briefly cover some special situations mentioned in the guidelines where patient characteristics influence management. Obesity comes up repeatedly.
Yes, it's a significant factor. Obesity is clearly linked to an increased frequency and severity of all stages of chronic venous disease, from telangiectasias right through to chronic venous insufficiency.
How does it impact outcomes after treatment?
Studies show that patients with higher BMI, specifically equals 35 kilometers donors, tend to have inferior outcomes in terms of clinical scores, RVCSS, and quality of life, CAVIQ 20, after intervention compared to those with lower BMI. However, it's important to note that significant improvements were still seen in all BMI categories after treatment. Obese patients still benefit.
How does obesity affect treatment choice?
For obese patients needing treatment for saphenous trunk incompetence, endovenous ablation techniques are generally preferred over traditional open surgery, stripping. This is mainly because wound complications like infection are much rarer after minimally invasive endovenous procedures compared to open groin incisions, especially in obese patients.
Are endovenous procedures harder in obese patients?
They can be technically more demanding. Veins are often deeper, making ultrasound visualization and cannulation more challenging. Tumescent anesthesia delivery might also require larger volumes or different techniques.
Are there recommendations related to obesity?
Yes, two new ones. First, regarding lifestyle, recommendation 91. For patients with chronic venous disease who are obese, weight loss should be considered for improving venous outcomes. This is class Tabloy level C. Second, regarding treatment choice, recommendation 92. For obese patients with saphenous trunk incompetence requiring treatment, endovenous ablation should be considered. Also class Thea, level C.
What about pregnancy?
Pregnancy is another well-known contributory factor. It increases the frequency of telangiectasias, particular veins, varicose veins, and recurrent reflux at the saphenofemoral junction. Oedema is very common, affecting up to 80% of women in the third trimester. Vulvar varicose veins are also common and tend to worsen with subsequent pregnancies.
Is compression recommended during pregnancy?
Yes, recommendation 93 is new. Elastic compression is recommended in pregnant women with symptom signs of chronic venous disease. This is class I, level B, based on studies showing benefit for symptoms and edema during pregnancy. Symptomatic patients should be reevaluated 3 to 6 months after delivery to see if intervention is needed once hormonal and mechanical factors resolve.
What if a patient is on anticoagulation? Can they still have venous interventions?
Generally, yes. The guidelines state that anticoagulation treatment is not a contraindication to sclerotherapy. For endovenous thermal ablation, a large study showed it was feasible, safe, and equally effective in anticoagulated patients compared to controls. A Delphi consensus advised against routinely bridging vitamin K antagonists for EVTA.
Does anticoagulation affect sclerotherapy outcomes?
It might. Patients should be advised that being on anticoagulation may reduce the success rate of sclerotherapy or necessitate extra treatment sessions compared to non-anticoagulated patients.
What about elderly patients, say over 75?
Endovenous thermal ablation under local tumescent anesthesia has been shown to be safe and effective in elderly patients, even those with multiple comorbidities compared to younger patients. However, age itself was found to be a significant risk factor for recanalization after EVTA. Odds ratio 1.03 per year increase in age.
And patients with very high venous pressure from cardiac issues?
Yes, patients with right heart failure or severe tricuspid valve regurgitation can present with impressive, sometimes pulsatile varicose veins due to the high back pressure. Standard management of the underlying heart failure is the crucial first step in these cases.
Okay, quick recap of special situations. Obesity worsens chronic venous disease. Weight loss should be considered, IICC. EVTA should be considered preferred treatment for trunks in obese, IIA, C. Compression is recommended for symptomatic pregnant women, IAB. Reevaluate post-delivery. Anticoagulation is generally not a contraindication for EVTA or sclerotherapy, but may slightly reduce sclerotherapy success. EVTA is safe in the elderly, but age increases recanalization risk. Manage underlying cardiac failure first in high-pressure reflux cases.
For you in practice, these points highlight the need to individualize care. Consider BMI and manage weight. Use compression in pregnancy. Don't automatically stop interventions for anticoagulation, but counsel appropriately. Be aware of age-related outcomes. And always look for systemic causes like heart failure when presentation is unusual.
Even with such a comprehensive document, the Guidelines Committee was very clear about identifying significant gaps in our current knowledge and areas needing future research.
Yes, and this is really important for guiding where future efforts should be focused. They provide quite a list.
What are some key areas highlighted?
There's a need for clearer, validated criteria for quantifying post-thrombotic obstruction using non-invasive imaging like duplex ultrasound, MR venography, or CT venography. Also, understanding the role of dynamic MR venography for assessing both deep obstruction and incompetence, and better ways to assess the adequacy of inflow for patients being considered for iliac vein stenting.
What about conservative measures and superficial treatments?
We need rigorous trials specifically looking at the impact of lifestyle changes and weight loss on chronic venous disease outcomes. We also need better evidence to define optimal treatment strategies for different clinical presentations and anatomical patterns of superficial reflux, which modality is best for which trunk, in which CEAP class, considering factors like diameter and depth.
Other gaps in superficial management.
Understanding the true rate of tributary regression after isolated truncal ablation. Getting long-term randomized controlled trial data specifically for small saphenous vein and anterior accessory saphenous vein endovenous ablation, and the big one, getting clarity on when and how to treat incompetent perforating veins, and in which patients it actually makes a difference.
What about post-procedural care and deep interventions?
The requirement for and optimal duration of compression after different endovenous modalities needs clarification due to conflicting evidence. Better patient selection criteria and evidence-based strategies for peri-procedural thromboprophylaxis, which product dose duration, are needed. For deep venous interventions, we need clear evidence-based criteria for selecting patients, particularly incorporating functional measures like venous claudication, which isn't captured well by current scoring systems. Better disease-specific quality of life scores are needed for assessing outcomes after deep interventions.
More on deep veins.
Yes, incorporating hemodynamic evaluation alongside morphology to diagnose obstruction is crucial, potentially avoiding overtreatment of anatomically narrowed but hemodynamically insignificant non-thrombotic iliac vein lesions. The optimal post-procedural anticoagulation or antiplatelet strategy after iliac stenting remains a major area of debate needing high-quality trials.
And for venous leg ulcers.
Understanding the role of routine iliac venous imaging in VLU assessment, and getting evidence on whether a strategy of radical elimination of all sources of reflux significantly impacts VLU healing recurrence compared to more selective approaches. This list really highlights that while we've made huge strides, particularly in superficial venous treatment, many questions remain, especially regarding optimizing deep venous interventions, managing complex cases like VLU and PVD, and refining patient selection across the board.
It certainly does. Okay, let's try to pull all of this incredibly detailed information together with some key clinical pearls and a final thought for you, the specialist clinician listener, navigating this field.
A fundamental point these guidelines reinforce, perhaps implicitly, is that not every patient with signs or symptoms of chronic venous disease needs an intervention. Reassurance, education, and simple conservative measures like compression and lifestyle advice are often the most appropriate first steps, especially in milder stages.
A crucial conceptual distinction to always keep in mind is the difference between treating the superficial system versus the deep system.
Absolutely. Superficial veins, if incompetent and causing problems, can often be eliminated, ablated, removed, sclerosed. Deep veins, however, are essential for limb drainage. Treatment goals there are different: restoring flow by removing obstruction, stenting, or managing the consequences of irreversible damage, reflux or obstruction, primarily through compression and lifestyle, with surgical options being very selective.
The guidelines clearly cement the shift in modern varicose vein management towards minimally invasive, ultrasound-guided endovenous techniques as the standard of care over open surgery for saphenous incompetence.
Yes, with sclerotherapy and transcutaneous laser being the cornerstones for treating these smaller reticular veins and telangiectasias, but always remembering that critical safety emphasis on careful technique and ultrasound guidance for sclerotherapy.
For deep vein obstruction, particularly symptomatic iliac lesions unresponsive to conservative care, endovascular stenting has become the primary interventional approach, although patient selection and long-term management strategies still require refinement.
VLU management absolutely requires a multidisciplinary approach. Compression is the non-negotiable foundation, high pressure, preferably inelastic, after mandatory ABI assessment. But critically, you must investigate the underlying venous pathophysiology with duplex ultrasound to determine if timely intervention, superficial ablation, or deep stenting is needed to promote healing and prevent recurrence.
These 2022 European Society for Vascular Surgery guidelines provide an incredibly valuable evidence-graded framework. They consolidate best practices where evidence is strong, but they are also refreshingly transparent about areas where recommendations are based on lower-level evidence or consensus, and where significant controversies or knowledge gaps persist.
Examples being the exact role of perforator treatment, optimal duration of post-procedural compression, the specifics of VAD use beyond an adjunct role, detailed guidance on deep venous stenting anticoagulation, and optimal management for complex PVD presentations.
And weaving through almost every aspect of modern chronic venous disease management is the absolute centrality of duplex ultrasound. It's not just a diagnostic tool anymore, it's an indispensable guidance tool for planning and performing interventions, assessing recurrence, and understanding VLU etiology.
It really is fundamental throughout the patient journey.
So here's a final thought to leave you with, thinking about your own practice. Despite these detailed guidelines and the array of new techniques, managing chronic venous disease, particularly in its advanced stages, in recurrent forms, or in special populations, remains complex. The evidence is constantly evolving, controversies exist, and patient factors are paramount. How can we, as specialist clinicians, best integrate this evolving evidence base, the nuances highlighted by the guideline grading, patient preferences, and our own local expertise and resources to truly optimize outcomes and effectively address the significant burden of this chronic, often progressive disease?
It's a continuous challenge, requiring ongoing learning, critical appraisal of new data, and careful application of these principles to each individual patient.
That brings us to the end of this extremely comprehensive deep dive into the European Society for Vascular Surgery 2022 Clinical Practice Guidelines on the Management of Chronic Venous Disease of the Lower Limbs. It's clearly a landmark document and an essential resource.
We hope this detailed exploration, going beyond just the recommendations to look at the evidence, the rationale, the controversies, and the practical implications, has been valuable and insightful for you as a specialist clinician working in this field.
Reflect on the complexities, the areas of certainty and uncertainty, and consider how these insights might refine your approach to managing patients with chronic venous disease. Thank you for joining us for this deep dive.